announcement for the AFREhealth conference to be held in Accra, Ghana. There's a website you may not see. It's www.afrehealth.net. If you visit that, you may get some information. Thank you very much. Now, let me let me welcome you to this afternoon session, and to say a very big thank you to CUGH, the organizers, especially Keith, for making it possible for us to have this panel. We have with us 6 panelists, and don't be scared, they'll stick to time, and we'll be out here in good time. We're going to share with you something about AFREhealth. AFREhealth stands for the African Forum for Research and Education in Health. It is a new body which was inaugurated in Nairobi, Kenya in August last year. And it's an initiative by the MEPI and NEPI initiatives which were funded by the US government and which made tremendous gains. My colleagues are going to speak to how the achievements under MEPI and NEPI and then speak about the future. So I'm not going to tell you too much. But AFREhealth is an interdisciplinary health professional forum that seeks to improve healthcare in Africa through research, education, and capacity building. AFREhealth is one example, I would say, of a very useful expenditure of US government funds. Let's clap for the US government, just in appreciation. So, and my colleagues will share with you some of the gains, North-South, South-South, interprofessional gains. So without, let me introduce my panelists. To my immediate left is Professor James Hakim. He's a professor of internal medicine from the University of Zimbabwe. James, can you wave? Thank you. And then next to her is Abigail Kazembe. Abigail is associate professor of nursing from the University of Malawi. And Abigail is also the deputy chair of AFREhealth, or one of the 2 deputy chairs of AFREhealth. Then after Abigail is Professor Marieke de Villiers from Stellenbosch University. She's a professor of family medicine, and she is also one of the deputy chairs of AFREhealth. So you can see I'm surrounded by 2 women, well supported. And then Miliad is a gentleman after, he's associate professor of pediatric surgery from Addis Ababa University, Ethiopia. And after Miliad is Judy Kaniola. Judy is a country rep for ICAP, and she'll tell you more about her role in AFREhealth. Last, but by no means the least, a man who needs no introduction, Professor Nelson Sawankambo, Professor of Internal Medicine, Makerere University, and if you've attended any session here, you would have seen this man multiple times. Thank you very much. So each of them has 8 minutes to present. They will be alerted when their time is up, or they have 2 minutes to time. We'll take all their presentations before we invite questions. So thank you very much. So James, thank you. And then please, as soon as James goes, you follow him. Thank you.
Thank you, Peter. Let me thank CUGH for this opportunity to present the MEPI program and its transition to AFREhealth. Those are my disclosures. Background to medical education in sub-Saharan Africa, the health workforce. Most of these statistics are really well known to the majority of people in this audience. 24% of the world disease burden is in sub-Saharan Africa, and only 3% of the world health workforce. And there are 1 to 60 doctors, depending on the country, per 100,000 population in Africa, compared to numbers like 60 per 100,000 in India, or 170 per 100,000 in Brazil. And in the United States, there are 4,650 researchers per million of population, but in sub-Saharan Africa, outside South Africa, there are only 46 researchers. So these are grim statistics which really demonstrate to you the background to why a program like MEPI is so essential. MEPI was conceived by PEPFAR, funded by PEPFAR and NIH, and the programs were developed by schools, the beneficiary schools in sub-Saharan Africa in collaboration with the United States and other partners. And the oversight of the program was by Fogarty International Center, OGAC, and HRSA. Now, there were 13 beneficiary schools in 12 countries, South Africa having 2 awardees. And the beneficiary schools were Makerere, Addis Ababa, Nairobi, Kilimanjaro Christian Medical Center, Eduardo Mendlane in Mozambique, University of Zimbabwe, University of KwaZulu-Natal, Stellenbosch University, University of Botswana, University of Malawi, University of Zambia, Kwame Nkrumah University of Science and Technology, and University of Ibadan. Now, in 5 of the primary awardee universities, they formed consortia with universities within their own countries. This therefore led to benefits going directly to 30 sub-Saharan African countries, even though the awards were made to only 13. The P in MEPI stands for partnership. So there were many partners, and most of these are from the United States, and a few from the UK and from other African countries that have strong medical education and research programs. I'll not read out all these names. The awards consisted of large programmatic awards, and then there were smaller linked awards and pilot awards. And the implementation at the schools involved close cooperation between the schools and ministries of health and ministries of education and the other partners, as I have indicated before. The objectives or the thematic areas of the MEPI program are, as I have put down there: increase in capacity, and there are 2 components there: increase in the number of health workers and improvement in the quality of medical education, and increase in retention of health workers, increase in regional research output and improvement in research capacity, establishment of communities of practice, and to ensure that there is sustainability of these innovations and programs. Broadly, the MEPI implementation fell into 3 headings: medical education, research capacity, and leadership. These will be expanded on by my colleagues. On your right, you will see MEPI leadership with Dr. Francis Collins, Dr. Eric Gusby, and Dr. Roger Glass at the MEPI Symposium in Nairobi last year, 2016. African leadership at various levels. At the school level, there was empowerment of decision-making by the MEPI leadership. There was guidance that was enabled through capacity that had been built within the MEPI program, in curricula and other scholarly activities. There was improvement in financial management, and indeed, the awards went directly to the schools, and they were able to establish strong management systems. And there was very strong cooperation with the Ministries of Health and Ministries of Education, and in-country coordination between the consortia and the schools brought about a sense of coordination, integration, cooperation, which was not common to the schools in those countries. And there was coordination also with licensing bodies. At the network level, most of the activities were centered on the MEPI Council, which now has transitioned to AFREhealth, and this was pivotal. The council was pivotal in the running of MEPI affairs, policy decisions, site visits, annual surveys, annual symposia, technical working groups, and these again will be expanded on by my colleagues, and agreements with other groups like USAID. As an example, in the upper left, the University of Zimbabwe students are actively engaged with MEPI leaders at a symposium in Harare. And the lower left, the University of Zimbabwe Vice Chancellor was receiving MEPI site visitors in his office. And on the right, I have shown some MEPI activities at the University of Zimbabwe, which mirrors activities in the other schools. There are several key MEPI documents and publications, such as the MEPI 5-year report and MEPI supplement in academic medicine, and these are available on the MEPI website and in journals. So, in conclusion, MEPI was a transformative medical education program which addressed key thematic medical education and research capacity needs of sub-Saharan African countries at a time of great need. Although there were 13 grantees, through formation of consortia, 30 schools directly benefited from MEPI activities. Through partnership with at least 25 US, UK, and other African institutions, MEPI benefited from an extensive network which enabled development of a robust agenda that revolutionized medical education and regional research in a substantial section of sub-Saharan African schools. A strong leadership program developed, and this is poised to transition and enhance the gains of MEPI in collaboration with NEPI to form AFREhealth. That's African Forum for Research and Education in Health. I wish to, well, this is just to show you that MEPI and NEPI will be involved in this transition to form AFREhealth, which will be described in greater detail later on. I wish to acknowledge the MEPI and NEPI schools and leadership and all other partners, funders, especially PEPFAR and NIH, Fogarty International and HRSA, and several well-wishers who have contributed to the achievement of all the innovations and what we have been able to see happen within the MEPI program. So thank you for listening.
Good afternoon. I'm going to talk a bit about the transition from NEPI, which was the NACE Education Initiative Partnership. And the outline of my presentation is to share with you what the goal of NEPI was, the historical background to NEPI, then the interventions that they carried out, and why the program was successful, and also share with you some challenges that were encountered, and also the transitioning from NEPI to AFREhealth. of NEPI was to produce sufficient numbers of nurses and midwives who are able to respond to the long-term health needs of communities in sub-Saharan Africa, where they provide up to 90% of services. Having that in mind, WHO recommends that they have to be about 230 health workers per 100,000 citizens. But looking at that graph, you can see that DRC, which was standing at 85 per 100,000, to all the way down to Ethiopia, which had 31 per 100,000 citizens. So you can see the critical shortage of nurses that was there. The background to the program is that it was part of the commitment of PEPFAR to train 140,000 health workers. In 2010, HELSA launched NEPI as part of its global nursing capacity building program. ICAP at Columbia University served as a coordinating center and implementing partner. And in particular, unlike MEPI, we had Susan Michael Strasser, who was the PI for the whole NEPI program. And NEPI started implementing activities in 2010 in the following countries: Lesotho, Malawi, Zambia, and in 2011, they moved to implement activities in Ethiopia and DRC, and then 2013 in South Africa. What were the interventions that they presented? NEPI supported interventions in each country with the objective to increase the quantity, quality, and relevance of nurses and midwives. Each country had its own specific needs, and this is why I think my colleague will go in detail to explain those specific needs. In total, NEPI supported 22 schools of nursing across the 6 countries that are just projected in there. Why was it a successful program? With NEPI, there was a strong local leadership of the program by governments through NEPI Technical Working Group. And each program was sitting at Ministry of Health level. You had a representative from colleges of nursing, the Ministry of Health, and the in-country program manager within the country. And leadership and priority setting was by the Ministry of Health. In other words, the ministry was asked what their needs were. So each country had to spell its specific needs. And the other fact that made it a successful program was that it enhanced partnerships within and between countries, and also with ministries of health and training institutions. I think that was particularly important because currently most schools operate in their own and the ministry operates in their own. But NEPI really brought the two together. And also the South-to-South collaboration, there was a lot of communication between other countries within the region, which is not normally the case. And also there were innovative educational transformation programs, which ICAP supported at each school of nursing. Although there were so many successes, but we also encountered a lot of challenges in implementing them. Given substantial role of nurses in healthcare delivery, the interventions were limited to the 6 schools of nursing, 6 countries and 22 schools of nursing. And you can see it's like a drop in the ocean. Therefore, there's need to scale up the urgently needed nurses to ensure quality and quantity for the purpose and practice of nursing at every level. Also, there is limited collaboration with other health professionals. When my colleague describes what the nurses were able to do, you can see clearly that it was, in their little world of nursing. And we felt some of the interventions needed to be shared across other professionals. And also, continuity of the program may be challenged despite strong sustainability plans because resources are limited. And also, while NEPI schools have successfully completed USG sub-awards, nurses nursing leaders lack skills needed to strengthen and adequately mobilize to scale up resources for implementing the interventions that NEPI had put in place. Therefore, there's need to build a regional body of nurse leaders to champion the profession and ensure that it is represented at decision-making forum or bodies. So nursing, currently what is has been planned is to have webinars for nurse leaders within the region. The actual migration from NEPI to AFREhealth resulted from a meeting that occurred in Addis, whereby the colleges of medicine, based on their report, were urged to invite, related health professionals in the country. So the nursing schools were invited to attend that meeting and share their experiences as a result of the NEPI program, which by then had come to an end. So the two institutions formed a new organization, which we now call AFREhealth, to move the agenda beyond the MEPI and NEPI programs. The good thing is that AFREhealth now includes the voice of nursing, and currently one of the two deputies chairs is from the nursing fraternity. At this point in time, I would like to acknowledge ICAP and NEPI at Columbia University for the data, especially Susan Michael Stresser, who was the PI of the whole program, and the US government funding AFREhealth, and my College of Nursing for funding this trip. Thank you.
Good afternoon, ladies and gentlemen. Thank you so much for attending this session. I must say that what you're seeing on the stage here together is unprecedented in African history, if I may say so, Mr. President. Right, so I need to talk about medical education. In 8 minutes, and our president is very strict, I will try and show you just a short snapshot of what happened in medical education in this MEPI project. So first of all, I must just acknowledge where I come from, because my dean is here from Stellenbosch University. And our project was called Stellenbosch University Rural Medical Education Partnership Initiative. We specifically focused on developing capacity and training in rural and remote areas. So I also need to acknowledge the MEPI coordinating centers. There were 2 of them, one at George Washington University, led by Professor Mullen, and one at HS in Kampala, led by Professor Mazwa. Okay, so I tried to put some of the activities in the shape of an M. Can you see it? Yeah. So obviously, I'm not going to read through all of them, but I just wanted to impress you to see that there were a lot of medical education activities going on. And there's a whole range of them, of which I will lift out a few today. So I think this will be available afterwards on the website, that you can go and look if there's something that you're specifically interested in. So, okay, I think one of the big things that happens is that new teaching methodologies were introduced. And for some of you, it may seem that, oh, but this is old. But for some of the schools in the MEPI project, it was really earth-shattering, these new teaching technologies, that we got the capacity and the resources to actually introduce. So if you look at this slide, you see the biggest bar. Do I have to point it to the screen? Okay, right. The biggest bar is e-learning. So that was in most of the schools introduced e-learning for the first time. Then another big bar was skills lab, simulation laboratories, we call it loosely skills labs. And then the third one, competency-based learning. And then there were others like team-based learning. There were a lot of interprofessional learning initiatives also introduced, although we were initially restricted just to medical education. Problem-based learning, there's the interdisciplinary, and non-electronic distance learning. So you could see a lot of new things, exciting things, which made a difference to medical education in Africa. So I decided to give you a little bit more on the biggest one, which is e-learning activities. So what actually was done? So on the left you see the CMS or the LMS, Learning Content Management Systems, that was introduced in 9 of the schools. These schools didn't have things like this before, which was an amazing step forward. So digital library, one of the activities there were around development of libraries, some on-site libraries, but also the development of resources, learning resources as a digital library. Then you see another big one that was done via e-learning with faculty training, and then there were a smaller one, simulated training, and then virtual classrooms. And just another one on e-learning, then the technology, because this is important. If you actually go and visit some of these schools like Tanzania and Botswana, and the PI sitting here, the handheld mobile devices, also in Ethiopia, made a huge difference to students going out to community-based training. And the other one I wanted to lift out is the video and teleconferencing. A big emphasis in medical education in MEPI was to move from centralized to decentralized training, or some people will call it community-based training, to address the human resources needs in rural and remote areas. And this we could not do before. Many of this, most of these guys could not communicate with our students at a distance, and this were introduced. So a lot of curriculum review and reform. Even at Stellenbosch, although the dean thought we were perfect, we had to still do some curriculum reform. So the yellow is new, that were new things happened since MEPI introduction, and that blue is then improved. So if you look at the first 2 bars, in terms of introducing core competencies, domains, and skills in curricula, there's quite a big yellow bar and a blue bar. So people who've already had those notions or those elements in their curricula reviewed and redone it. Again, objective structured clinical exam, or fondly known as OSCEs, which again some of you may think, we all do that. This was quite well implemented in MEPI as a way of standardizing assessment across the board. And then we come back to the simulation labs, quite a number of new ones or changes. And again, if you go and look at the infrastructure established and the equipment at some of these sites, it's really wonderful to see. Okay, so you cannot train students without staff, and a lot of faculty development related to medical education was done. You see that the biggest one here is the one for research, but I see that this one, 27% medical education research, and I'll say a little bit about that later. There was quite a large bit of faculty development done there, and then of course this one, a pedagogy training. It's like a really big word, but it means how to teach better. So often we just teach because we're a professor in something. So we really went out to do faculty development in the pedagogy of medical education. And in that way, created sustainability, something that will never go away and that will continue going forward. Okay, so medical education research, you would have read some publications that said, James said there's 1% of biomedical publications comes from Africa, and almost none in medical education. If you go to the International Medical Education Conference, few and far between. But what we managed to do in this project, which was really amazing, is to, in all the publications that we published in this project, that you can see that 109 was a medical education focus. I mean, that's really hardcore education focus in terms of showing evidence or effect of all these interventions that we've implemented. And what we feel also that Africa was lagging behind in showing that what we are doing is making a difference, that this is creating tremendous sustainability and creating a lot of evidence for ourselves to see if all these new things people say we must do, if it works in our context. Right. Okay, and then I just need to say something about what did we do in terms of strengthening HIV training. And it is wonderful actually to see this graph, and all of the schools did a lot of HIV training, undergraduate or pre-service, like you say in this country, postgraduate, as well as in-service. A lot of in-service training happened in MEPI on HIV. And now I need to show here and read there. If the topics is stigma reduction, diagnostics, treatment, medication adherence, etc., prevention testing. And this is a wonderful slide to show, especially if, you know, medical education is in essence a health system strengthening effect. We sometimes ask, what is the direct link between training a medical student and making a difference to your burden of disease? So it's wonderful to have graphs like this to show that through training people that you do make a difference to the burden of disease. So then my last slide, I was just asked to talk about the MEPI technical working groups, which we fondly call TWGs. This was one of the strengths of MEPI, and James talked about partnerships. The way that we come to know each other and work with each other is one of the absolute strengths. So if I need something or I want, I just email or phone one of my colleagues. So the MEPI technical working group was formed for these 8 areas. Let me just go through them. It's community-based education and e-learning, M&E group, and a research support, developing research support centers, graduate tracking, one for medical education research, competency-based education, and the library and information science. So if you look at, let's look at community-based education. There were workshops held. There were, in 2 countries, there were leads for this technical working group in African countries. And then we worked with our other partners, our North partners. There were workshops held. There were studies done. There were a number of publications coming out. And I must compliment Makarere, of course, that led some of this. And this has developed a community of practice in community-based education or decentralized education. These people know each other. They are in the field. They are on the ground people. And they will take this concept forward sustainably so in the future. So we feel that this technical working groups in AFREhealth, it's something that we want to continue. And I hope that if you see something that you're interested in here, that you will be interested to join in these technical working groups, which we will take forward. And here is also a publication by Professor Mullen and Fryworth from George Washington University that you can read. So then finally, just thank you. I think first of all, I thank you to Dr. Keith Martin for giving us the stage today. Really, your vision and your generosity is much appreciated. And we hope and trust that from this will come more collaborations. Secondly, to my colleagues on the stage and other colleagues and maybe in here, without you as people and as intellectual and academics, this would not have happened. And then lastly, of course, to America, the American people, without you, your enthusiasm and your belief and your funding, this would not have happened. Thank you very much.
What do I do? He's the one changing. Good afternoon. My name is Miliard. I'm from Ethiopia, and I'm also involved in MEPI. So today I'll talk about what we thought what will replace MEPI is transforming healthcare in Africa, which we have established AFREhealth. This is our motto. Mainly my talk is what we have achieved in promoting research in our region and capacity building and publication, what we have through MEPI. The first thing what we have done is establishing research support center, that is institutionalizing and establishing a research support center. And this research support center will help in finding opportunities, and pre-award proposal preparations for the researchers, and also post-award grant management, like by establishing grant office, and also then followed by safety policies and procedures like IRB, and ethical committees and others. This is what we have done as a baseline to facilitate research in all the MEPI grantee institutions. When you see, that was our plan, but in 2005, we have almost achieved, as you see, the yellow line, we have almost achieved in most of the MEPI schools in establishing the research support center. This is, then after establishing the research support center, the second step was, research capacity building of faculty, that is training. We have trained in research methodology, ethics and biosafety, grant writing, project management, and research mentoring and exchange. When you see this one, the research capacity building, grant writing training, which was given in my university, that is in Addis Ababa University, you can see how it has developed from 2013, even though MEPI starts in 2010, but we have trained almost most of our faculties on research training on grant writing. We have also trained on research methodology and research ethics almost in most of the medical schools. As you see, we have, it goes down because when you start training, we start almost all the faculties, and the new faculties will keep on training. That's why it looks like it's going down towards 2015. And 2016, we have also continued, most of us, we have continued as a no-cost extension, and the research work has also increased in all these 13 MEPI schools. The other thing is, to bring our research as a culture on medical students. We have spent a lot of time and effort to bring medical students, or to involve medical students in research by student research mentoring, and also some of the faculty also on faculty research mentoring. So the output of this research, capacity building, then capacity building infrastructurally, also capacity building, humanist capacity building. The third output is on publication. As you see, we have the publication areas are all very much diverse, and these are the publications which are supported by MEPI. You can see we have tried to address the medical issues of our continent, our region, like on HIV, non-communicable diseases, mental health, child health, and surgery. So the number of publications which we have so far done by MEPI up to 2015. By the way, in 2016, we don't have the data from all countries, but I'll show you my country. But there is a rise in publication in all MEPI schools. Now we have reached like close to 400 publications, which are directly supported. These are directly supported by MEPI project. You see publications in my university from 2011 to 2015. We have published like 1,100 publications, which are totally with MEPI and from other projects. But we can see that contribution of MEPI is very high because of by increasing capacity of researchers, as well as research support system which we have provided through the project. When you see the publication by research area, as Marike said, medical education is the most the most research area which is dealt, and through that, you can see 113 research publications have come out of MEPI. As already said by Marike, when you Google about medical education in Africa, 5 years ago, you may not get any article, but now, whatever article, most of the articles which you get on medical education in Africa are supported directly by MEPI project. And you can see we have also addressed the medical conditions of our continent or our region, as you see, like on HIV, on NCD, on maternal and child, as you see, it goes on. So we have almost touched all problems, all areas of research in our continent or in our region. In malaria, trauma, anything. The other question was, most of the publication which comes out of Africa are not, Africans are not first authors. But through MEPI, by building the capacity of the African researchers, we have managed to change this trend in most of the institutions which are supported by MEPI. You can see the trend, and most of the publications which you see are entirely or mostly the first authors are Africans, unlike what was used to be before. And these publications, because of their high quality, are almost all of them are published in high impact journals. And you can see the journals which are already mentioned, some of them are highly reputable and high impact journals internationally. So this shows, how MEPI has helped, local researchers in producing high quality journals, high quality research, so that it will be internationally acceptable, also internationally addressed, or by on international standard for any consultation or any references. So our contribution is not only to Africa, but also to the world as well. Most of the MEPI works are presented in many symposiums, and as you see, on medical education, on HIV, on e-learning, these are the areas which we are mainly dealt with. So it is also the contribution of MEPI in, widely sharing the experience of the universities in sub-Saharan Africa, what we have done on promoting medical education in the last 5 years. So we have seen at different times presentation in many international and national conferences. The other area is on community-based research. Almost all MEPI institutions have worked on community-based research by involving students, and some of them by involving postgraduate trainees and as also public health trainees. We have tried to involve directly medical schools to work with communities. This is to bring the link between universities and community, so they can address the community problems directly, and also they have helped in changing or in supporting policy changes in their ministries and also in the continent as well. So in conclusion, when you see the number of publication and the quality of publications through MEPI in the last 6 years are very, very encouraging. Publications, almost most of the journals are published on high impact international and reputable journals, and as African authors have come, and most of them as first authors, and research that addresses locally relevant public health problems are addressed as well, and presentations have been helped to disseminate the health issues of low and middle income countries to to most of on most of the conferences. Addressing community issues through research, and also research is also used as a retention mechanism, because we support researchers working in upcountry, the young medical doctors, so they stay there till they finish their research. So it also has helped as a retention mechanism, and also by promoting them on their career. So MEPI has built a legacy that should be continued to harness the opportunities created. AFREhealth is trying to maintain this legacy, which we have already started. We are at the momentum of building research capacity, or in general MEPI. Then I think this is what we have to continue. Thank you very much.
Good afternoon, everybody. Thank you for sticking with us this far. It's not easy, Sunday afternoon, lunchtime. I'll try to ease your pain a little bit. So my name is Judy Hanyola. I'm working with NEPI, the N side of the partnership, and ICAP at Columbia University's regional nursing advisor for Africa. And I'm just going to talk a little bit. There's so much that can be said about what NEPI has done, but I'm going to look at some of the NEPI innovations in education and training for nurses. I think, like my colleagues have said before me, we know that the graph, we know that there are too few health workers. In Africa, Abigail alluded to the numbers, I think, and James as well, to the dearth of healthcare workforce. And it's even worse in the profession of nursing because, as you know, the bulk of healthcare in Africa is done by the nursing profession. So I'm going to talk about innovations in education and training. So what are some of the NEPI education interventions? Like Professor Mariette mentioned when she talked about the MEPI side of it, we've done a lot of work on infrastructure, on curriculum, on faculty, on clinical skills. We do, apart from just the in-service work, pre-service work, we do a lot of work on the in-service side, and of course, like my colleagues in MEPI, the partnerships. This is just a quick example of a school that we refurbished. This is in Lesotho, which is in the southern part of Africa, and this is a skills lab that has been renovated for the nursing students. This is also an example of resource lab, library. I can tell you that some of the nursing schools had books as old as 1957, before NEPI. There's a school whose latest textbook was published in 1957. So NEPI came in and updated and upgraded all the textbooks, the core textbooks, the materials that were required by nurses to study. This is just an example of one of the things that NEPI has done, and that's in e-learning. This is a nurse in Kenya, and she's accessing an e-learning platform that NEPI has put in place. Another innovation of NEPI was what we call the competency-based curriculum. Prior to that, Africa has the legacy from the colonial days where all our curricula were theoretically based, and much of what happened is that the students who came out of this were really theoretical, and there was a big gap between theory and practice. So we revised the curriculum to make it more competency-based. So we looked at what are the competencies or the skills or the tasks that these nurses need to perform when they come out into the workplace, and then develop curricula backwards so that then we look at the tasks that the nurse has to do, we develop a framework, and then we do the curriculum. So what this has resulted in is that now nurses are more competent. When I did my nursing, I know, for example, we did not learn HIV when I went to nursing school. But lo and behold, you come out and there they are, half the ward is full of HIV patients, and you didn't learn it, so what are you supposed to do? So we took this and revised our curricula accordingly. Another innovation was the introduction of new courses. I think, like Professor Mariette explained also on the medical side, we introduced new courses just in light of the fact that most of the curricula was very historical, very old, and not in tandem with what was going on out there in the field. So for example, in DRC, we have an advanced diploma in nursing, and what this has done is that it has equipped nurses with higher skills, because oftentimes some of the countries, each country in Africa is different, most of the countries train nurses at a very low level, and yet when they come out, we require nurses at a certain higher level. So we developed an advanced diploma in nursing in DRC. In Lesotho, we developed a post-basic. Simply means you go through a course in nursing, and then post that, we added a component of midwifery. I think most of the sessions you've sat in has talked about maternal and child health, which is a big problem in Africa, and this requires us to have midwives. We added a Bachelor of Science, still in Africa in nursing, higher level qualifications in nursing, bachelors and masters are still not there, so we added that as well. In Zambia, we did a diploma in comprehensive nursing and midwifery, and what this is showing is that we stopped having siloed nursing staff. I know when I went to nursing school, we all were like hospital nurses, and we were trained as RN to work in the hospitals. But life has changed, things have shifted. We know that our disease burden is community-based, and therefore we revised the curricula and started these new courses to reflect that. We shortened the duration of some of the training. For example, in Zambia, their Bachelor of Science in Nursing is 6 long years. So this makes it very tedious and long and expensive to train a nurse with those higher level qualifications. We shortened the training of this nursing, this course to 3.5 years. Clinical skills lab, again, like MEPI. NEPI also did some clinical skills simulation labs. We refurbished, we equipped. In some schools, they didn't have them. When I went to nursing school also, we didn't have an opportunity to work in the clinical skills lab. And what this has done is that it addresses not only the theory to practice gap, but it enables the development of competence and confidence. When you're able to work with the simulated patients, you develop confidence to then work on the real life patient when you meet them out there in the ward or in the community. And this, of course, has increased our clinical judgment, but has allowed nurses also to practice in a controlled and safe environment. E-learning, I've mentioned that. This is just an example of one of the e-learning programs that we have. We have a program on option B+. We are developing one on pediatric HIV. We also have one on the new differentiated care that has come up. And all of this means that nurses are able to access this new information at their fingertips, literally. And again, thanks a lot to PEPFAR, US government, and HRSA for enabling a lot of these innovations. This is just an example of one of the things that we do. And why I put this here is because oftentimes nurses do not have the ability to learn on the job. And so because of developing these interactive case studies, the nurse can actually, when she's on her desk, in the hospital, in the unit, in the community, she's able to quickly see this. This is a very good learning tool that we do when we train nurses we train nurses right where they are, and this is an example of interactive case studies that are very easy to use as we teach the nurses. So what has this achieved broadly? NEPI has increased enough nurse midwife workforce, effectively combating maternal and infant mortality, HIV, AIDS, communicable diseases that you've heard throughout the duration of this conference, which, as you know, have decimated populations in Africa. There's increased student clinical skills and competencies through construction, innovation, and refurbishment of the skills lab, strengthening nurse-led teaching and learning models. Oftentimes, when I went again to nursing school, we're trained by physicians who, while they have the science, don't often understand what nurses do or what nurses need to do. So having the nurse-led initiative has helped nurses to teach other nurses, and this has been very well received. An example is the NIMAT program, the Nurse-Initiated Management of Antiretroviral Therapy. Key countries that have done this is South Africa and Kenya, and this is a model that has allowed for nurses to be able to manage broadly the stable patients who are, HIV positive and be able to manage that huge number of patients. Supporting the nursing policy environment, which of course impacts education and training. So like Abigail mentioned, we work with the technical working groups at the Ministry of Health, which has helped us to then be involved in policy making. Retention of the workforce through training in rural, hard-to-reach areas. For example, Lesotho has a lot of mountainous rural places, and NEPI has worked in Lesotho to ensure that the nurses who train there remain there and they don't all come to the urban areas or to the towns, and they're therefore able to care for populations in the rural areas. Task shifting is another one. Nurses are now able to take on some of the physician roles upwards, and downwards community healthcare workers are taking on some of the nursing roles because, as we mentioned earlier, there is a huge gap in health workforce. Multidisciplinary teaching and learning with other cadres. So for example, one of the things that NEPI has done is the first 2 years of the basic nursing school, we do this with the medical doctors, and this has been very good because it helps us work as a team with the physicians, with the pharmacists, and when we come out, we take that on and are still able to care for patients with that in mind. Last but not least, strengthening the participation of African nurses and midwives to participate in South-to-South exchange and learning. Thank you for listening to me.
Ladies and gentlemen, let me just start here. Since I'm the last speaker, I'm just trying to round up things so that you have it in a package. So AFREhealth, which has been talked about many times, is where we are now. And having had that good experience about MEPI and NEPI, one of the things that has been occupying our minds is where do we go from here? And therefore we formed AFREhealth. What is the genesis of AFREhealth? Has been mentioned. But let me summarize very briefly. First of all, when we got the grants 5 years ago, 6 years ago, we knew that those grants would come to an end. And so what happens in the end? How do we institutionalize and sustain the achievements that had been gained by MEPI and NEPI? So sustainability was a major issue of concern for the MEPI PI Council, which later became expanded to include the nurses, as you've heard. And therefore, moving forward, we knew right from the beginning, and we were puzzled over the years, or we tried to think carefully what would happen thereafter. You heard that the AFREhealth was launched last year in Nairobi, and these beautiful photos illustrate or show you the kind of people who were present at launch. And it gave us optimism and hope that indeed the world was appreciating what we are doing under MEPI and NEPI. Hence, the issue of bridging the gap. What is the gap? That after MEPI and NEPI ended, there would be a gap. What would be in place to be able to continue with the activities and achievements that had been gained? So in bridging the gap, AFREhealth represents, in our view, a new thinking and approach to address African challenges or health challenges through a concerted effort of many professions coming together. Do recall that MEPI was largely for physician training, although as it went on, it was transformed and there were many professions coming in. NEPI was just for nurses. We thought that moving forward, it's absolutely necessary that various health professions come together and work together because health challenges, particularly the more complex ones, cannot be addressed by one health profession alone. So the vision for AFREhealth was that we should be an African-designed initiative that is African-owned and African-led, facilitating African institutions to initiate and sustain transformations in research and education that were vital to advancing the quality of health services on the continent and therefore accelerate improvements in health status. Because we in Africa are tired of seeing statistics that depicts us as being the worst in many different situations. So, what is the value proposition that we have for AFREhealth? Indeed, we've been asked many times, what is the value proposition here for AFREhealth? As I've mentioned, that what we put on the table is development of an African interprofessional health movement that promotes interprofessional approaches to the education and research for service delivery. One might say that what is new. In Africa, there isn't a lot of places that practice an interprofessional approach, both in education and research, with the sole purpose of improving the quality of health services and therefore health status of the people. As it mentioned, complex challenges cannot be solved by one profession only, and we want to minimize the tribal approach by health professions by working in those silos. Another question that we are often asked is, so what will be the niche for AFREhealth? From what I've said already, you would appreciate that our niche, as we envisage it, is interprofessionality and interdisciplinarity in health, in education, and research and service delivery. Transformation of health professionals and the approaches in that area are indeed very critical. In the last 6 years, we've seen a lot of transformations going on, as has been summarized for you. That we will also have meaningful engagement of various stakeholders that can impact on education and research in general. So, it is very central to our thinking that as we move forward, partnerships and networking are vital to our success, especially collaborating south to south within Africa, across national borders, but also even within countries. It's not unusual that good institutions exist in a country, and yet there's hardly any collaboration between institutions in the same country. We want to accelerate that collaboration and also across countries within Africa. But of course, we don't forget the north-south or south-north partnerships, which are also critical to moving forward. So the other value that is added to the value that AFREhealth is going to add to our future is to de-emphasize this silo approach. And we can't emphasize that enough. We must de-emphasize the silo approach in education, in research, and services. However, AFREhealth brings complementarity to the existing initiatives because there are professional associations, for example. And again, the question being asked is, what are you going to do about the other health professions, associations, and initiatives that exist? That we want to be complementary to those endeavors and minimize competitions. We know we can't eliminate it, but at least minimize competition. AFREhealth should have convening power and ability to bring together various health professions to jointly address key issues that we define. And this should contribute to advancing the educational standards in Africa for improvement of quality, quantity, as well as addressing equity issues on that continent. There should be mutual learning and learning from each other, cross-learning, across the networks and partnerships. I thank you for your attention.
Can you join me once again to give my colleagues a hand? Thank you. They did their best to stick to time, and I'm grateful for that. Let me acknowledge a few people here who have been with us from the very outset of MEPI and NEPI. And there are several others. I only limit to a few, so don't be offended if you're not mentioned. Let me acknowledge Dr. Roger Glass, but forget International Center. Roger, thank you. And Dr. Wafa El-Sadr. She was the unseen force behind NEPI. And then I've seen Dr. Joe Colas, who was part of the coordinating center. There are many others who were there with us, but I just wanted to limit the acknowledgement to just these. Now, we've heard 6 presentations, and I would like at this point to leave whatever time we have to questions, so or contributions. So please, there's a mic there. If anyone wants to ask something, can you line up and just get your question? Thank you very much.
Yeah, hi, Quentin Ashburn, Vanderbilt University. What I wanted to Yeah, I was at the AFREhealth meeting in Nairobi, and I think some of you know we started talking about education, and there's a big emphasis on education, and that's very exciting. And I'm just wondering how we might explore, and being cognizant and sensitive of not wanting to export Western education into Africa, how we can explore stronger connections between CUGH and AFREhealth. And we have an education committee at CUGH, which I currently chair, which has 8 very, very vibrant subcommittees with enormous expertise. And we're trying to definitely try and get members from Africa onto those committees. And on the education committee, we have some from Stellenbosch now. One idea may be to map the TWIG, the technical working groups, onto our subcommittees. I could see some synergies between each of those. A second quick question here is, I'm concerned, maybe it's not right, that as MEPI sort of falls away, that the research, that the dollars and granting dollars are going to go more and more towards scientific research. Now, I'm not saying that's not important, it is important, but I'm wondering what your perception is of sustaining the educational initiative, which I very much do see as a health strengthening initiative, versus pure research dollars, which is good, but I think some universities don't yet have the lab capacity to produce postdocs and employ them in the country. So at some level, I think that's a little more premature than the educational health strengthening initiative for production of healthcare workers that I think is important. So those two questions.
Please go ahead.
Lillian Dudley, Stellenbosch University, and I was part of our SAMEPI project, Leading Health System Strengthening. So thanks very much to all the speakers, and I must congratulate MEPI and all the partners on the tremendous success of the project. I think it shows that we don't just build up individual institutions, but by collaborating, we're able to, I think, at one of the first MEPI seminars, somebody said, if you go together, you go further, and I think that's certainly what we've seen. My question is really about how AFREhealth not just sustains the achievements of SAMEPI, and I hear that a huge focus is going to be more on interprofessional education, but the initial goal of SAMEPI was around strengthening health professions education in Africa in order to impact and strengthen health systems. And I think we did a huge job in focusing on the production side, both in terms of numbers and also in terms of fit for purpose around competencies to work in and strengthen health systems. But I don't know if we really focused on the aspect of retention. So my question is, how is AFREhealth going to take us to the next level in retaining the health professionals that we're producing and reducing the brain drain or the flight of health professionals out of Africa? Thank you.
Thank you. We'll take the next one, please.
Yes, Bob Suskind, Dean of the California University of Science and Medicine. I'd like to congratulate all of you on the success that you've had with the MEPI and the NEPI program, and I want to wish you all the best of luck in the next step forward. One of the things that I wanted to share with you is that in putting together this new medical school in Southern California, we have developed, and I was interested in one of the slides about silos in terms of education. And what we have done is put together a curriculum which has a fully integrated basic science system-based curriculum that has a clinical, that is basically the clinical presentation curriculum that we are just about completed, have just about completed, and will be making available to any medical school in the United States and internationally the opportunity to work with the institution in that. And I think one of the things that that I've realized in terms of medical education in the U.S. and internationally is that the traditional courses in anatomy, biochemistry, physiology can be much more effectively utilized in a system-based curriculum that has a clinical relevance to the students. And so this curriculum, which will be finished probably in July or August, we would be willing to, um, I won't say, we'll make it available to any school in Africa or in the world if they're interested in collaborating with us in terms of this opportunity. My roots in Africa go way back before some of you were born. When I was a medical student, had the opportunity to go to Cameroon as a Peace Corps physician in Senegal. So I have close ties with Africa and really have enjoyed what you have accomplished through PEPFAR in terms of bringing up to date the medical educational process that you're all involved with. So congratulations, and look forward to working with you in any way we can.
Thank you. Please.
Brad Dreyfus, University of Arizona, and Global Emergency Care. Work in Uganda, building essentially a mid-level training program, which is becoming a diploma through Embrar University of Science and Technology. Thank you. That was a perfect setup for my question. And it goes along with the co-development of emergency physicians in Uganda, which is starting this fall. Thank you, Dr. Nelson, Professor Nelson. And the nursing end, there's this piece for the specialized clinical officer and specialized nurse. Working with Allied Health Council, we've been trying to figure out how best to get that licensed and how that's going to be run between the physicians and the clinical officers versus the nursing, which are separate structures. Any insights on how we can better support these structures and moving forward would be greatly appreciated. And thank you.
Thank you. Please.
Ishmael Amara, and Chief of Training in Global Mental Health at the National Institute of Mental Health. This is a question and maybe a call to action, so you all could take it however you want. But before I ask my question, I wanted to say thank you for all the good work that you guys are doing. It's really appreciated from people like us. My question is, and it stems from my experience as a program officer and dealing with like training and dealing with other program activities at the National Institute of Mental Health is, and I'll borrow this term from another field, which is how can we improve the ease of doing business in institutions in Africa? Because and this may lead to, it's not only training individuals or healthcare professionals, but increasing the capacity or the soft skills of institutions to conduct research, and that would contribute to the long-term sustainability of this field. Because as you guys all know, the biomedical and research enterprise in this country is huge, and it's one of the biggest generators of improvement in the economy. So how do we do that in Africa in the coming years? And good luck on your endeavors.
Thank you very much.
Thank you once again for the terrific presentation. My name is Jerry John Nuttall, and I'm a PhD candidate from Drexel University and also a nurse from Ghana. From your presentation, I've observed that currently you are operating in only few universities in Africa. I want to ask, what are your plans of expanding your project to other universities or schools in Africa? And secondly, I want to ask, in Africa, I know that there are a lot of political interferences in health professional training. I want to know, how are you breaking these boundaries, or what are your plans of breaking some of these boundaries? Thank you.
Thank you. Thanks, please.
Hello, my name is Pearl Enney. I am a research fellow at the National Institutes of Health right now and MD candidate at the University of Texas McGovern Medical School in Houston. Wanted to say thank you, all of you, for your work with AFREhealth. My question really is about partnerships between American medical schools and African medical schools. My father is a product of medical education at the University of Ibadan, and I've seen in his career how his training in Nigeria and in practice in Nigeria has been beneficial to his practice here in the U.S. and vice versa. And so I'm curious about the opportunities available for medical students in training like myself to be able to um, engage in AFREhealth, perhaps in clinical rotations, and perhaps kind of build more sustainable partnerships at that level. So at the training level, especially for you know, people like me who are, you know, definitely products of Africa and are very interested in giving back and kind of maybe reversing some of the brain drain that is experienced with my father's generation. Thank you.
Thank you.
Good afternoon. My name is Erica Dankwa Asante. I work at UT Southwestern's Office of Global Health in Dallas, Texas. First, I wanted to say it's very empowering, actually, to see all of you here. This is the thing we talk about a lot in international development in our office here in the States. We're upset and frustrated that a project doesn't go beyond the point of its funding, and you all have done that. So I'm sure you're a motivation to your colleagues and also to young people. My question is that in the work that you've done, and particularly with nurses, because in the future, although I'm not a nurse in public health, I would like to work with nurses in the future, particularly in maternal and child health. I wanted to know, are you training nurses in particular areas to be masters so that they can go from one particular location to many other locations to train others within their country and even within the region?
Thank you. Wafa, please.
I don't know how you're going to be able to answer all these questions.
We're keeping track of them. No, we'll do that. We're keeping track of them. No, we will. Please.
Okay.
Go ahead, Ed.
Wafa Al-Sadr from
we are still within time.
ICAP at Columbia. This is a comment rather than a question. I think the training activities have been very fundamental, but I think this is just a comment in terms of AFREhealth in the future. I think another important value of MEPI and NEPI has been at the policy level. And I think it's kind of important moving forward that that's not lost, at least from the NEPI perspective, and I know for MEPI I'm sure as well. It's been very important to put nursing profession at the, you know, give it the value, the appreciation to be able to influence policy at a national level. And I think moving forward, issues around retention and job descriptions and so on and so forth are largely influenced by policymakers. So I'm just curious again as how AFREhealth will also position itself not just as training, but also in terms of trying to influence policy, which is fundamentally in the end what's going to make all of this endeavor succeed, hopefully.
Thank you very much. We have quite a number of questions, but what I'll do is just to highlight some of the points that were raised and perhaps even respond to some and then leave the others to my colleagues. Now, there was a question on what relationship are we developing with CUGH and how can we continue to kind of sustain some of the skills and research vis-a-vis grant writing, etc., etc., etc. Well, I would say that that is one of our primary goals. We've actually already started collaborating in many ways with the CUGH. We have several meetings with the executive director, with the board, the president, the vice president, and a few others. Fortunately for us, we have Nelson, who also happens to be an outgoing board member as a member of AFREhealth. So we've been engaging with them very closely, and we hope to continue. We've met some of the subcommittee heads, even at this meeting, and continue to have discussions. And we hope to scale it up and actually build a much more permanent relationship. In fact, our vision is actually, in some respect, to be the CUGH of Africa, if you would. So that is, and they are the best mentors. With Wafa's question, I think at the point is absolutely right. Without engaging with our policymakers, we are not going to make any progress. And I think some of the successes, even on MEPI, was actually the realization that we needed to be talking with the ministries of health, education, and other policymakers from the outset. Nelson that was how it started. And I think going forward, that is the only way AFREhealth can actually have any grounding. And so I think that is something that is going to be picked up. There were some requests for student nurse placements, student medical school placements. Maybe I'll start from the end there. Nelson, can you tackle some of the questions that you can respond to? If medical students are interested in coming to, say, Makerere, what would they have to do? Can you pass?
I'll leave that question to somebody else because I don't quite get the question.
Okay, I'll tackle it. All right, so now what about retention? There was a question on retention. What kind of strategies do we have in place to make sure that some of the personnel that we train remain in country? Maybe you can tackle that.
Okay, retention, as we all know, is a very complex issue. It's not only dependent on how you train and who you train and where you train them, but depends on a number of other issues that may be a little outside the area that educational institutions can influence. So ministries are very important in contributing to the retention issue by providing a kind of environment where professions work and feel satisfied with the work that they do and that they are well supported. And therefore, AFREhealth, one of the things we are doing with MEPI is to talk to, as has been mentioned, to the ministries of education, ministry of health, bring in a discussion with public service and ministry of finance. Those kind of discussions need to continue because they create an environment where which promotes and supports health workers. I did mention in my presentation engaging stakeholders. Put very simply, that is a very complex endeavor, and stakeholders are many and at different levels, and they all contribute to ensuring retention.
Thank you. Judy, was there any question for you? No?
Maybe to add on retention, among many reasons for attrition is career development structure, and is one of the issue which pushes physicians out of their country. So through MEPI we have trained many physicians on subspecialty levels, like on infectious disease and non-communicable diseases and emergency medicine and also others. So this has helped, for retaining faculty, and also building the research capacity of faculty has also contributed in retention through that by gaining knowledge of research and publishing many articles and promoting within the faculty. So it is in all whatever we do in our MEPI program, directly or indirectly has contributed in retaining the faculty. So this is what we've done, and I think this also continues despite, in the absence of MEPI, may not be in the same velocity as it started, but it's going on.
Thank you very much.
Maybe I'll try and answer some of the questions related to nursing. Thank you very much for them. What NEPI schools can be used? We work in 6 countries with 22 schools, which are all available, and maybe the details can be hashed out. Integrating the nurses with the doctors and clinical officer regulatory body. At the moment, I think this is one of the endeavors that AFREhealth is going to look at moving forward, because at the moment each profession has its own regulatory body based on its scope of practice and what needs to happen within the profession. But I think one of the things AFREhealth is looking at is how to have some overarching areas where the professions are cross-cutting. For example, maybe basic education, some of the scope of practice that cross-cuts, and that's what I can say maybe to answer that. Somebody asked about expanding to other schools in Africa. Yes, this is one of the initiatives that AFREhealth is looking at. NEPI worked primarily in the east and southern part of Africa because just of the nature of HIV and the burden of disease, but definitely, yes, we are looking at integrating with the Francophone Africa and West Africa as well. Maybe the other question regarding nurses was, are we training nurses to be masters? And yes, we are. We are training nurses to be masters so that they can then cascade that information to other nurses or to other places, and I can give you the details after this. Thank you.
Thank you very much. Marek, any comment?
Right, I would like to address Quentin and Bob and that lady whose father in Nigeria. The theme of those questions is how do we actually bring all of us together? We are all enthusiastic and we want to work together to make a difference. So I think you've actually given, Quentin has already given one of the answers is in terms of working with an organization like CUGH. In terms of, I don't understand your subcommittee structure, but you mentioned the TWG, so that you actually bring the people who are the key experts in the field together, and they need to get to know each other. So we can do sort of broad networking here, but bringing those people together in those working groups will continue the work in that particular area. That's also the key to your question, I think, about how sustain the medical education research going on. It's a specialized area. People don't have time for that. If we can bring the experts together, even, with little things we can do something. Then in terms of, and the same with the curriculum that I think the guy Bob said, he's got something to offer. We all got something to offer. How do we bring together? And the question of medical students, Milliard started within MEPI a student organization. So we got to bring the students together also in that way. And we professors can talk about it. So again, I think let's use the energy where it is, and maybe the structure then of CUGH and AFREhealth, but I'm a practical person, and put something in place that we can get to work and do these things.
Thank you.
Maybe I can respond to one or two observations which you made. I think the one other observation was AFREhealth and the CUGH. Yesterday, I think there was a capacity building meeting by CUGH on the Education Committee, which Andrew Dickens planned. And I'm happy to report that I attended that meeting and flashed out the issues and the gains that NEPI had made and how we don't want to lose those. So there was a follow-up meeting over lunch hour just to iron out things. And I believe this is the beginning of moving the agenda forward. And there were also other nursing institutions in the US, for example, that would be interested to work with us. In terms of whether nursing students from here through AFREhealth can work in Africa, I think that is welcome, because one of the things that we talked about was partnerships. So we have already started having some MOUs within Africa, trying to promote that, and we hope that we can extend that to Africa and beyond. In terms of capacity building, I think there's, within the next AFREhealth meeting, there will be a capacity building workshop which involves other health professionals, just to make sure that the gains that MEPI and NEPI had achieved cannot be lost entirely. There was one on political interference. Okay.
Yeah, thank you. Many of the contributions have really been offers to collaborate or to share some best practices, and that's really great. And that's what partnership is all about, and this is how MEPI and NEPI have been able to achieve these milestones which we have shared with you today, purely because of partnership. Partnership with US and other partners, and partnership within Sub-Saharan Africa itself. We've learned so much from each other. Initially, each school put together an application which looked different from the next school. But if you look at what activities have been carried out in each of the schools, they're extremely similar. Because eventually people realize that there's so much that could be shared. So the advantages, the added value of partnership will always continue, and the more partners, the more contributions that come in will always be welcome. And just to underscore the question of spreading the message to other medical schools, somebody asked about that. As I mentioned in my presentation, the award was made to 13 schools. But some of the schools realized that really in a small country, you can't improve one medical school and leave the rest of the medical school and hope to be able to improve health delivery in that country. So they quickly put together consortia, and the gains of the awardee school were spread throughout the country. And as AFREhealth, that is really our wish, that it's not only 30 schools. In 2010, there were something like 150 medical schools in sub-Saharan Africa. There are probably 200 or so by now. We would like all these 200 schools to benefit from all these innovations, from all these partnerships, and so on. And once, an innovation has been created, it's so much easier to be able to transmit that. And we have seen that most of the innovations that have developed through MEPI and NEPI have been so transformative. There are innovations which you hardly see them taking up within a particular community. But in our schools, in our medical schools, a lot of what we have done have really blossomed. And that is something that we would like to see the whole of Africa benefit from.
Thank you very much, James. I think there was one question on political interference. That is always a problem, but again, that's not something we must engage governments. I learned something from the National Academy president yesterday, that you try to be as neutral as possible. We engage with all governments and make sure that we are not seem to be aligned. There was a question from the NIH, and it was on how do they struggle to do business with African schools. It's all about capacity, and especially in the area of research, through MEPI and NEPI, there was a research capacity strengthening. So I think that is one area that you can continue to support going forward. You find it to get increasingly easier for you to do business with the schools, research. We thank you very much. It's late, but we're very grateful for you too. Thank you.